Hello students, welcome to the EPG Pathshala. I am Professor Richa Tanwar from the Women's Studies Research Center, Kurukshetra University. Today I am going to talk about the module Women and Health from the paper Social Issues Regarding Women. The objective of the module is to make the reader understand the health status of women in India as well as some important health indicators related to women. In the introduction, like most cultures across the world, Indian society has deeply entrenched patriarchal norms and values. Patriarchy manifests itself in both the public and private spheres of women's lives in the country, determining their life chances and resulting in their qualitatively inferior status in the various socio-economic spheres. It permeates institutions and organizations and works in many insidious ways to undermine women's right to dignified lives. It is well recognized now that in patriarchal settings such as India, hierarchical, unequal gender relations and unequal gender norms impact women's sexual reproductive health, reproductive choice, and act as significant obstacles to access services and facilities. As individuals, it should be possible for us to articulate a vision that seeks to bring together holistic concerns for women's bodily integrity and autonomy, together with a wholly legitimate focus on family and gender. A growing concern among women health advocates today is that women's views and perspectives must be incorporated in policies and programs that are designed for them. Healthcare is the responsibility of the constituent states and territories of India. The Constitution charges every state with raising the level of nutrition and the standard of living of its people and the improvement of public health as among its primary duties. The right to life spells the right to health. The Supreme Court has interpreted the right to life as stated in Article 21 of the Indian Constitution as the right to live with dignity. The right to health is thus integral to the right to life as held by the Apex Court. Women's right to make reproductive choice is a dimension of personal liberty as understood under Article 21 of the Indian Constitution. A woman's right to privacy, dignity, and bodily integrity should be respected. Reproductive rights include a woman's entitlement to carry a pregnancy to its full term, to give birth to subsequently raise children, along with the right to contraception, contraceptive choice, and information. Gender inequality was the main theme of UNFPA's State of the World Population Report 2000. India is one of the few countries in the world where women and men have nearly the same life expectancy at birth. The fact that the typical female advantage in life expectancy is not seen in India suggests there are systematic problems with women's health. Indian women have high mortality rates, particularly during childhood and in their reproductive years. The health of women depends on their emotional, social, and physical well-being, which are determined by different social, political, and economic contexts of their lives. India, being a large country, has a diverse population socially, culturally, and economically. Yet the common major problem that women here face in availing healthcare is inequality between men and women. Among women of different geographical regions, social classes, and indigenous and ethnic groups across the country. The health of women depends on their emotional, social, and physical well-being, which are determined by different social, political, and economic contexts of their lives. India, being a large country, has a diverse population socially, culturally, and economically. Yet the common major problem that women here face in availing healthcare is inequality between men and women. Among women of different geographical regions, social classes, and indigenous and ethnic groups across the country. There are several factors responsible for the current status of women, and one is the culture itself. Women are subjected to selective malnourishment from birth. There is a strong preference for the male child in several states, promoting illegal sex determination and female feticide. This not only poses threat to the expectant mother's physical and mental health, but also imbalances the sex ratio, thereby giving rise to several other social problems. If health is defined as a state of complete physical, mental, and social well being, and not merely the absence of disease or infirmity, it follows that existence is necessary condition for aspiring for health. The girl child in India is increasingly under threat. In recent decades, there has been an alarming increase in the child sex ratio 0 to 6 years in the country. Access to technological advances of ultrasonography and India's relatively liberal laws on abortion have been misused to eliminate female fetuses. The discrimination against the girl child is systematic and pervasive enough to manifest in many demographic measures for the country. For the country as a whole, as well as in rural areas, the infant mortality rate is higher for females in comparison to that for males. Usually, though not exclusively, it is in the northern and western states that the female infant mortality rates are higher. A difference of 10 points between the two sex-specific rates not being uncommon. The infant mortality rate is slightly in favor of females in the urban areas of the country as a whole. But then, urban India is marked by greater access to abortion services, and unwanted girl children often get eliminated before birth. It has been commented in the context of women's health that sustainable well-being can be brought about if strategic interventions are made at critical stages. The life cycle approach thus advocates strategic interventions in periods of early childhood, adolescence, and pregnancy, with programs ranging from nutrition supplements to life skills education. Such interventions attempt to break the vicious intergenerational cycle of ill health. Women's health in India. The dynamic interplay of social and environmental factors have profound and multifaceted implications on health. Women's lived experiences as gendered beings result in multiple and significantly interrelated health needs. But gender identities are played out from various locational positions like caste and class. Women's physiological makeup calls for special nutritional supplements. Menstruation and childbirth are iron-depleting physiological processes. Calcium needs to be continually supplemented during a woman's life cycle as a bulwark against osteoporosis in later life. The predominantly vegetarian diet of Indians does not fulfill many of their nutritional requirements. Further, cultural practices disadvantage women in many ways and add to their poor nutritional status. It is customary in many households across the country that the women should eat last and eat the leftovers after the menfolk have had their food. The choice of dishes prepared is often in keeping with the preference of the male members of the household. The NFHS 2 estimates that 35.8% of women in the country suffer from chronic energy deficiency with a body mass index BMI of less than 18.5 kg. The proportion of such women is highest in Odisha, 48%, followed by West Bengal, 43.7%. On the whole, the eastern states of the country fare worse than the others in this measure. However, barring a few small states, in the rest, a quarter or more of the women have a body mass index below 18.5 kg. The NFHS 2 also shows that at the national level, more than half, 51.8% of the women in the reproductive age group suffer from some form of anemia. With the exception of Kerala and Manipur, levels of anemia are consistently higher for the other states. The proportion of women suffering from some form of anemia often being more than 40%. Assam leads with 69.7% of its women being anemic, Bihar 63.4%, Meghalaya 63.3%, and Odisha 63%. Maternal undernutrition is a major challenge in India, with more than one-third, 35.6%, having low body mass index. Linked to it is malnutrition. Every sixth death in India pertains to an infant, with 40 infants dying within 1 year of birth. Similarly, malnutrition continues to adversely affect a majority of women in India, with the result that every third woman is undernourished and every second woman is anemic. According to NFHS 3, 58% women were married before the legal age of 18 years, and 74% were married before reaching the age of 20 years. The prevalence of anemia for ever married women has increased from 52% in NFHS 2 to 56% in NFHS 3. Though maternal mortality ratio has made an appreciable progress and declined from 212 to 178, a fall of about 16% during 2007-2009 and 2010 and 12, the concern still remains as child marriages are still practiced in India and calls for regular monitoring of maternal mortality ratio in the population. Health policies in India and women's health. India was the first country in the world to take up a national family planning program in 1951, and many other countries took up such programs later. The Government of India, through its Integrated Child Development Services, that is the ICDS program, that was started more than 3 decades ago, had sought to reduce both socio-economic and gender inequities through opportunities for early childhood development. In the 80s, the concept of well-being of the family was concretized and given definite shape by making universal immunization program, oral rehydration therapy, and safe motherhood programs prominent components of the family welfare program. In the early 90s, these programs were integrated and called Childhood Survival and Safe Motherhood Program. Yet there are evidences that health programs were not women-oriented, rather they were women-targeted. Just as similar was the prevalence of a provider-controlled approach to family planning, rather than a user-controlled approach, turning women into human guinea pigs. Health perspectives changed through 2 landmark conferences. The Program of Action (POA), adopted by 179 governments at the International Conference on Population and Development (ICPD), Cairo, in 1994, marked a new understanding among world bodies that population, development, and women's empowerment are inextricably linked. That gender is a critical dimension of reproductive and women's health was established in the Beijing Conference in 1995. A focus was brought on the mother and child health as a key element in Indian health policy through this paradigm shift. India became signatory to both the conferences and made a start by introducing the Reproductive and Child Health (RCH) program in October 1997 and the National Population Policy in March 2000. To better address concerns for women and the girl child, the government in the last decade felt it necessary to design interventions for adolescent girls through programs like the ICDS. The 11th plan of the Government of India recognized the need to move beyond the traditional focus on family planning and reproductive health to adopt a holistic perspective on health so that the other health needs of women are not neglected. In the year 2000, India, along with 189 heads of state and government, had committed to reducing the numbers of mothers dying by 2015 in their Millennium Declaration. The Millennium Development Goals Task Force of UNFPA on Child and Maternal Health indicate that the term women and children should not be a tagline for vulnerability and SOS for rescue, a trigger for pangs of guilt. Instead, women and children must be seen as the present and future workers in their economies, caregivers of their families. They are human beings who have rights, entitlements to conditions, including access to healthcare that will enable them to protect and promote their health, to participate meaningfully in the decisions that affect their lives, and to demand accountability from the people and institutions whose duty it is to take steps to fulfill those rights. While women in India face many serious health concerns, this module focuses only on 5 key issues: health, reproductive health, violence against women, nutritional status, unequal treatment of girls and boys, and HIV/AIDS. Because of the wide variation in cultures, religions, and levels of development among India's 25 states and union territories, it is not surprising that women's health also varies greatly from state to state, region to region. Fertility intertwined with women's health. The fertility rate in India is 4.4 into 10, that is 4.5 in rural areas and 3.8 in urban areas. However, there are large differences in fertility levels by state, education, religion, caste, and place of residence. Uttar Pradesh, the most populous state in India, has a total fertility rate of over 5 children per woman. On the other hand, Kerala, which has relatively high levels of female education and autonomy, has a fertility rate under 3.2, and Bihar has a rate of 5. High levels of infant mortality combined with the strong son preference motivate women to bear high numbers of children in an attempt to have a son or two survive to adulthood. Place of residence, education, and religion are strongly related to both fertility and contraceptive use. More than half of married women with a high school education or above use contraceptives compared to only one-third of illiterate women. Not surprisingly, the total fertility rates for these two groups are significantly different. 4 children for illiterate women compared to 2.2 children for women with a high school education or above. Over 1 lakh Indian women die each year from pregnancy-related causes. Maternal mortality and morbidity are two health concerns that are related to high levels of fertility. India has a high maternal mortality ratio, approximately 190 deaths per 1 lakh births in 2013. This ratio is 57 times the ratio in the United States. The high levels of maternal mortality are especially distressing because the majority of these deaths could be prevented if women had adequate health service, either proper prenatal care or referral to appropriate health care facilities. Few pregnant women receive prenatal care. The most recent National Family Health Survey was conducted in 2005-2006. It found that in the 4 years preceding the survey, 37% of all pregnant women in India received no prenatal care during their pregnancies. The proportion receiving no care varied greatly by educational level and place of residence. Nearly half of illiterate women received no care compared to just 13% of literate women. Women in rural areas were much less likely to receive prenatal care than women in the urban areas. 42% for urban areas and 18% for the rural areas. Majority of births in India take place at home. The place of birth and type of assistance during birth have an impact on maternal health and mortality. Births that take place in non-hygienic conditions or births that are not attended by trained medical personnel are more likely to have negative outcomes for both the mother and the child. Anemia. Anemia, which can be treated relatively simply and inexpensively with iron tablets, is another factor related to maternal health and mortality. Studies have found that between 50 and 90% of all pregnant women in India suffer from anemia. Severe anemia accounts for 20% of all maternal deaths in India. Severe anemia also increases the chance of dying from a hemorrhage during labor. Crime against women. While violence is a serious threat health issue for Indian women, it is difficult to say how widespread it is because data are limited. The data that are available show an increase in the reported level of violent crime against women. However, such statistics do not reflect the actual levels of these crimes because many incidents, particularly domestic violence, go unreported. The most media sensationalized type of violence against women in India is dowry death. When a woman marries, her family provides the husband's family with gifts, clothes, household goods, cash. In many instances, the demand for these gifts does not end with the marriage but continues, as the husband's family persists in making additional dowry demands for years after the wedding. A dowry death is defined as the unnatural death of a woman caused by burns or bodily injury occurring within the first 7 years of marriage, if it can be shown that woman was subjected to cruelty by her husband or her husband's relatives shortly before death in connection with a demand for dowry. 8,618 dowry deaths have been reported in 2011. Malnourishment. Numerous studies indicate that malnutrition is another serious health concern that Indian women face. It threatens their survival as well as that of their children. The negative effects of malnutrition among women are compounded by heavy work demands, by poverty, by childbearing and rearing, and by special nutritional needs of women, resulting in increased susceptibility to illness and consequent higher mortality. While malnutrition in India is prevalent among all segments of the population, poor nutrition among women begins in infancy and continues throughout their lifetimes. According to the National Family Health Survey, Indian children have amongst the highest proportions of malnourishment in the world. More than half, 53% of all girls and boys under 4 years of age were malnourished. Excess female deaths. Differential treatment of girls and boys in terms of feeding practices and access to healthcare is among the factors responsible for higher female mortality. As a consequence of their lower status on the overall, Women experience discrimination in the allocation of household resources, including food and access to health services. Boys are breastfed longer than girls, 25.3 months versus 23.6 months on an average. Boys who are ill are more likely to be taken for medical treatment than are girls. Causes of death for children aged 1 to 4 show girls dying at a higher rate than boys from accidents and injuries, fever, digestive disorders, all causes that are related to living conditions and negligence. HIV/AIDS in India. The HIV/AIDS epidemic in India is spreading rapidly and increasingly will affect women's health in coming years. A recent study estimated that between 2 and 5 million Indians are currently infected with HIV. The highest rates of infection are found in population groups with certain high-risk behaviors: sex workers, intravenous drug users, and sexually transmitted disease patients. However, infection is also increasing in the general population. According to NFHS 3 2005-6, the key findings in household characteristics are that 1/3 of India's households are in urban areas, with 2/3 in rural areas. Half of the households have 4 or fewer members. 14% of households are headed by women. More than 1/3 of India's population, 35%, is under age 15. Only 5% is age 65 and above. Among children under 18 years of age, 5% have experienced the death of one or more parents, both parents. In all, 83% of children under 18 years of age live with both parents and 13% live with one parent. Housing, electricity, water, toilet facilities. 55% of households have no toilet facilities, down from 64% at the time of the NFHS 2. 3/4 of rural households have no toilet facilities. 88% of households use an improved source of drinking water, 95% of urban households and 85% of rural households. But only 25% have water piped into their dwelling, yard or plot. 1/3 of households treat their drinking water to make it potable. Half of those that treat their water strain the water through a cloth, and almost 1/3 boil the water. Fertility, age at first marriage. The median age at first marriage among women is 17.2 years. Men get married more than 6 years later, at a median age of 23.4 years. Almost half, 46% of women aged 18 to 29 years, got married before the legal minimum age of 18. Fertility level. Fertility in rural areas is 3 children per woman, much higher than in urban areas, where the replacement level fertility rate of 2.1 children per woman has been achieved. The greatest differentials in fertility are by wealth and education. At current fertility rates, women in the lowest wealth quintile will have 2 children more than women in the highest wealth quintile. Teenage pregnancies. Among young women 15 to 19 years, 16% have already begun childbearing. Young women in rural areas are more than twice as likely to be mothers as young women in urban areas. In Jharkhand, West Bengal, and Bihar, at least 1 in 4 teenage women have begun childbearing. These statistics reflect the fact that the majority of women in India married during their teens. If all women were to have only the number of children they wanted, the total fertility rate would be 1.9 instead of 2.7. Infant and child mortality. The infant mortality rate in India is steadily decreasing. Infant mortality is currently estimated at 57 deaths before the age of 1 year per 1,000 live births, down from the NFHS 2 estimate of 68 and NFHS 1 estimate of 79. However, more than 1 in 18 children still die within the first year of life, and 1 in 13 die before reaching age 5. Perinatal mortality. Perinatal mortality, which includes stillbirths and very early infant deaths in the first week of life, is estimated at 49 deaths per 1,000 pregnancies that lasted 7 months or more. Maternal health antenatal care. Among mothers who gave birth in the 5 years preceding the survey, almost 3/4 received antenatal care from a health professional, 50% from a doctor, and 24% from other health personnel. Younger women were more likely than other older women to receive antenatal care, as were women with more education and women having their first child. More than 1 in 5 mothers received no antenatal care. Almost two-thirds of women in Bihar did not receive any antenatal care. For 65% of births, mothers received iron and folic acid supplements, but only 23% consumed them for the recommended 90 days or more. Delivery care. 3 out of every 5 births in India takes place at home. Only 2 in 5 births take place in a health facility. In postnatal care, early postnatal care for a mother helps safeguard her health and can reduce maternal mortality. Only 37% of mothers had a postnatal checkup within 2 days of birth, as is recommended. Most women receive no postnatal care at all. Anemia. Anemia is a major health problem in India, especially among women and children. More than half of women in India, 55%, have anemia, including 39% with mild anemia, 15% with moderate anemia, and 2% with severe anemia. Anemia is particularly high for women with no education, women from scheduled tribes, women in the 2 lowest health quintiles, women who are breastfeeding or pregnant are also more likely to have anemia. HIV/AIDS. As far as awareness of HIV/AIDS is concerned, only 61% of women in India have heard of AIDS. Even in urban areas, only 83% know about AIDS. Young women 15 to 24 are only somewhat more likely, 65%, than older women to have heard of AIDS. In women's empowerment and decision making, married women were asked who makes decisions on their own health care. Making large household purchases, making household purchases for daily household needs, visiting their own family or relatives. Only 37% of currently married women participate in making all 4 of these decisions. Women in nuclear families and women who are employed for cash are more likely to participate in these household decisions. The National Health Policy 2015. The context, National Policy, Health Policy of India 2015, addresses the urgent need to improve the performance of the health system. It is being formulated in the last year of the Millennium Declaration and its goals, in the global context of all nations committed to moving towards universal health coverage. Given the two-way linkage between economic growth and health status, the National Health Policy is a declaration of the determination of the government to leverage economic growth to achieve health outcomes, and an explicit acknowledgement that better health contributes immensely to improved productivity as well as to equity. The National Health Policy of 1983 and the National Policy of 2002 have served us well in guiding the approach for the health sector in the 5-year plan and for different schemes. Now, 13 years after the last health policy, the context has changed in 4 major ways. Firstly, health priorities are changing. As a result of focused action over the last decade, we are projected to attain the Millennium Development Goals with respect to maternal and child mortality. Maternal mortality now accounts for 0.5% of all deaths and 4% of all female deaths in the age 15 to 49-year age group. This is still 46,500 maternal deaths too many and demands that the commitments to further reduction must not flag. The primary aim of the National Health Policy 2015 is to inform, clarify, strengthen and prioritize the role of the government in shaping health systems in all its dimensions, investment in health, organization and financing of healthcare services, prevention of diseases and promotion of good health through cross-sectoral action, access to technologies, developing human resources, encouraging medical pluralism, building the knowledge base required for better health, financial protection strategies, and regulation and legislation for health. Goal, principles, and objectives. The attainment of the highest possible level of good health and well-being through a preventive and promotive healthcare orientation in all development policies and universal access to good quality healthcare services without anyone having to face financial hardship as a consequence. The objectives are to improve population health status through concerned policy action in all sectors and expand preventive, promotive, curative, palliative, and rehabilitative services provided by the public health sector. Achieve a significant reduction in out-of-pocket expenditure due to healthcare costs and reduction in proportion of households experiencing catastrophic health expenditures and consequent impoverishment. Assure universal availability of free comprehensive primary healthcare services as an entitlement for all aspects of reproductive, maternal, child and adolescent health and for the most prevalent communicable and non-communicable diseases in the population. Enable universal access to free essential drugs, diagnostics, emergency ambulance services, emergency medical and surgical care services in public health facilities, so as to enhance the financial protection role of public facilities for all sections of the population. Ensure improved access and affordability of secondary and tertiary care services through a combination of public hospitals and strategic purchasing of services from the private health sector. Influence the growth of the private healthcare industry and medical technologies to ensure alignment with public health goals and enable contribution to making healthcare systems more effective, efficient, rational, safe, affordable, and ethical. Women's health and gender mainstreaming. Women's health issues and concerns go far beyond maternal health. The ability of the health sector to address these issues needs to be strengthened. Despite the introduction of new technologies, access to safe abortion services and for reproductive tract illness remains a major gap that must be seriously addressed. One major concern is the health response to victims of gender violence, ranging from sexual assault to acid attacks on women. While measures to prevent these are the focus, the health system must also bear the costs and undertake whatever it takes to access the appropriate services for these victims. At another level, women's access to healthcare needs to be strengthened by making public hospitals more women-friendly and ensuring that the staff have orientation to gender sensitivity issues. So students, let us now summarize what we have learned in this module. The health of women depends on their emotional, social and physical well-being, which are determined by different social, political and economic context of their lives. There are several factors responsible for the current status of women. One is the culture itself. The dynamic interplay of social and environmental factors have profound and multifaceted implications on health. Maternal undernutrition is a major challenge in India, with more than 1/3 having low body mass index. India was the first country in the world to take up a national family planning program in 1951, and many other countries took up such programs later. Many of the health problems of Indian women are related to or exacerbated by high levels of fertility. Maternal mortality and morbidity are two health concerns that are related to high levels of fertility. Place of birth and type of assistance during birth have an impact on maternal health and mortality. Numerous studies indicate that malnutrition is another serious health concern that Indian women face. The HIV/AIDS epidemic in India is spreading rapidly and increasingly will affect women's health in coming years. The primary aim of the National Health Policy 2015 is to inform, clarify, strengthen, and prioritize the role of the government in shaping health systems in all its dimensions. Women's access to health care needs to be strengthened by making public hospitals more women-friendly and ensuring that staff have orientation to gender sensitivity issues.